afternoon, good morning, everyone. Welcome to our SUNSTAR Conversations PRO series on oral health challenges at different life stages. My name is Rachel, and I will be your host today for this 7th webinar. First, I would like to inform you that if you are joining through the registration platform, Eventbrite, you may want to switch and follow the YouTube link at the bottom of the screen in order to enjoy the full screen mode and also use the chat box to ask your questions. Now, for the past months, we have received several speakers to discuss about oral health challenges such as dental hypersensitivity, oral frailty, behavioral change from pregnancy to the aging patient. Today, we will have a special, which will not be on the life stage per se, but on the people taking care of patients without being professionals themselves. I mean, the caregivers. Caregivers are often people without specific training in oral health care. So what can an oral care professional do in order to help these caregivers to provide the best possible oral care to these patients? To learn more about this topic, we are glad to welcome today two experts on the topic. First, I would like to introduce to you our first speaker, Dr. Larisa Musić. Larisa, hello. Nice to have you with us.
Hello, Rachel. I hope you can hear me. Everything is fine with the connection.
Everything is fine. Thank you. So, Larisa, you are a teaching and research assistant at the Department of Periodontology in the School of Dental Medicine at the University of Zagreb, Croatia. Would you like maybe to give us a little bit of your connection and background around this caregiving topic?
Well, my connection to this topic in great part is clinical, because even when I was an undergraduate student, I was a part of a student initiative that as one of the activities provided training for caregivers and individuals in nursing homes on oral care. And then later on, I got the opportunity to join my mom, who's an anesthesiologist and palliative care doctor. So I first-handedly witnessed how home-based informal and formal care looks like. And nowadays I work as a clinician. I work at the Department of Periodontology, as you said, and I'm actually the cog in the wheel of the integrative approach to oral care, because I work as the dental/periodontal professional collaborating with caregivers and the individuals in need.
Great, you may now have that a lot of input to give to us. We are looking forward to listen to you. But before that, I would like to introduce your co-speaker, because indeed we have a second invitee. You will be joined by Dr. Falk Schwendicke. Hello, Falk.
Hi,
glad to have you with us as well.
Thank you. Thanks for having me.
Falk, I think you are the head of the Department of Oral Diagnostics, Digital Health and Health Services Research at the Charité University Hospital in Berlin, Germany. Similarly, would you like to give us a little bit of your connection to the caregiving topic?
Yes, thank you. Yes, we here in Berlin in our hospital, but especially in my department, we have been working on that topic from a scientific perspective for quite a while. We founded a junior research group about 4 years ago and really worked on this to get together an overview about the epidemiologic and public health challenges we are facing, but also the implementation issues. Why is oral care and oral health so poorly in many elderly in care homes? And stepwise, we have developed a concept there, which we by now already implemented in our own care center, where we have outreach activities for nursing homes. So we are in close contact with formal and informal caregivers there, and understand, I hope, a little bit better than we did some years ago, what issues people have there and how we can address them.
So your field is quite complementary to Larisa's one. So we are really interested in hearing from both of you today, and very happy to have the opportunity to bring to our audience your clinical expertise on this caregiving topic. So shall we start directly and classically with, let's say, a general overview on caregiving with its definition, the forms it can encompass. Larisa, would you like maybe to kick off this conversation with a general overview on caregiving?
Thank you, Rachel. Very, very gladly. So when we talk about caregiving and caregivers in very simple terms, These are individuals that tends to the needs or concerns of persons that are in need because they have some sort of short or long-term limitations that might be caused by an injury, by an illness, or any sort of disability. And as you said, we generally divide them. We divide them in formal and informal caregivers. And starting with formal caregivers, these are individuals that provide services that are paid for. These are individuals that receive training for these tasks. And without making a general assumption, but I think that the first thing that comes to everybody's mind are nurses in the hospitals or nurses that work in nursing homes. But these trained individuals are much more. They can also provide formal home-based care or even formal care in community-based day centers, so where certain individuals spend time and they can receive care as well. On the other side of the spectrum, there are informal caregivers, and I think that today we will be focusing maybe a bit more on them as well. These are individuals that usually are from the social circle of the person in need. Very often, these are family members, spouses, children, but they can also be people from their community, such as neighbors or friends. And what discerns them from formal caregivers is that they rarely receive the education for all the tasks that they provide. And the tasks that they provide vary from some daily activities such as eating, bathing, going to the toilet, to instrumental activities such as transportation, paying the bills, tending to the household. Something that not majority of the people think when we talk about care is companionship and emotional support. And this is something that informal caregivers give to the person in need, to the care recipient. And finally, what again, without making a general assumption, I think comes to everybody's mind first is the nursing and the medical tasks, but they're not the only tasks that informal caregivers provide. And I just want to sort of leave breadcrumbs here because even when we will be talking about clinical tips, I will be getting back to this because it's important to highlight the value of informal caregivers. They are greatly outnumbering the formal caregivers. As I said, they rarely receive the necessary training that they need to. And what we know from different reports on caregiving is that informal caregivers experience very long duration, much longer than formal caregivers, and high intensity of caregiving. So there's also a lot of strain on them. And that being said, just a few words about care recipients, which I think is quite important to set the stage about the importance of oral health and oral care in this population of individuals, is that in the last SUNSTAR Conversation PRO, Professor Schimmel and Tsakos spoke about the elderly population, and they've highlighted how we are generally globally growing older. And as such, the number of individuals that are older and that will require and are requiring care is also growing. However, we need to bear in mind that not every single care recipient is an older person. They can be of any age group. They can be children. They can be teenager, young adults, and of course, older adults. But the reason why I'm pointing this out is because their oral care needs are different depending on the age group that they are. And it's really important to individualize this oral care, and we will speak about that later. Because of this different needs, as I said, oral care is different, but it's so important to tend to it because what we know today and it's spoken actually more about it today, is the connection between the oral and the general health. And here I would like to invite Falk to continue and to speak more about it, because he has also published a lot on the topic, on this connection and why it's so important, and why, after all, today we're here and we're discussing this thing, why we're putting so much stress into oral health.
Yeah, many thanks. Then I will just take it up there. I think before I go into that link between oral health, and especially oral health in the elderly and oral hygiene in the elderly and systemic diseases, what I would like to push once more is that we are facing a very heterogeneous group with quite complex needs in comparison to what these people needed with regards to oral care maybe 40 years ago. Because what we are seeing is an interesting shift in the diseases in our societies, especially the oral diseases. So in former times, for example, dental caries was a disease of mainly children and adolescents, and because they got caries and caries experience in that early age, usually they lost teeth then soon after, in their 30s and 40s, and then with 60, 65, the vast majority of people didn't have any teeth and was dented. And that has changed massively. With all the preventive successes, we are seeing increasingly good oral health and tooth retention also in children, adolescents, adults, and by now even the first seniors, and increasingly lower amount of people with full dentures, for example. We just published a study some years ago on the rate of people, the prevalence of people with full dentures in Germany, and we are projecting it to decrease to less than 5% in the 65 plus years old in 2030. So it will be a rare phenomenon to have full denture at some point in the next years. And that obviously impacts on caregivers, because full denture is a completely different thing to care for than own teeth. You can take the denture out and clean it. Okay, it isn't done by many people in care homes, because even that is a task which comes with a number of emotional aspects, but also skills aspects, which people in care homes, former caregivers in care homes, suffer with or struggle with. But dealing with own teeth is even more difficult. And if you look at these own teeth, and that's the second issue, and I'm coming closer to what you mentioned, Larisa, if you look at these own teeth, they then suffer from a range of issues. They increasingly suffer from root caries, because many of these individuals have receded gums, and because they still have teeth, and they need quite a carbohydrate-rich sweet diet because of a number of factors. I think we'll touch this later on. And they get root caries. And on the other hand, because they have teeth, they get periodontitis, something they couldn't get 40 years ago when they didn't have teeth. So what we are seeing is that, for example, the vast number of periodontitis cases in our society will be in that group, in the 70, 75 years old plus. So generally, from epidemiologic perspective, we are looking at something which we call a morbidity compression. Fewer diseases in the young people, more diseases and more problems in the old people, and then we are dealing with another problem. These people, that kind of population, is increasingly facing difficulties in visiting us in our normal dental settings. So it's really quite a conundrum. It's difficult to deal with this because it's shifting, more and more people are getting old, they can't reach us, traditional dental services are not available to them. And so we are really looking at difficulties both in servicing, dental servicing, and in preventive caring for them. This is what we're discussing here. And what you hinted at, Larisa, is, I think, from my perspective, quite relevant, because we know that dental diseases, that oral diseases, are associated with general health. I wouldn't stress too much the link between periodontal disease and everything in our body. I think this is something which I see increasingly, that the periodontologists and the perio community is trying to establish links with everything. I just recently read a paper where they established the link between periodontal disease and problems with male potencies and that kind of stuff. I was joking about these kind of things years ago. Now they finally published a paper about it. So I wouldn't push this too much, but what we are really seeing is that certain systemic diseases are indeed linked to periodontal disease, like, for example, diabetes. We know that there's a bidirectional effect. It's hard to control the diabetes if periodontal disease isn't controlled. And on the other hand, if the diabetes isn't controlled, then you won't manage periosis successfully. So there we really see the need to link up with, for example, the doctor for diabetes. And establish joint care concepts. And I think here the formal and the informal caregivers have quite a role. And the same thing, and that's especially relevant in that group of very old people who need care, who need assistance, is the link between oral hygiene and oral biofilms and pneumonia. And that link is a deadly one. We know that poor oral hygiene increases the risk of dying from pneumonia by around 50 to 100%, so it doubles the risk. And on the other hand, if you maintain a good oral health, if you control the dental plaque or also the plaque on dentures, you can reduce that risk by 40, 50%. We have the studies for that. And I think these are two good examples where we have strong data linking oral diseases and oral conditions with systemic health. And these are also two good examples why it's important to care for people's health if they need our assistance, if they need our help. And I think the general situation is really calling for our attention. Dental services need to address these needs, and at the moment we are very much focused on dealing with people who come to our practice. But for these people, which we are talking about today, for these people, that's not the solution. We need other solutions.
Well, I would just like to add some things to this. As a periodontist, I'm not going to defend our stances. What I do think it's important is to raise awareness about the potential link, because especially in terms of caregiving and oral caregiving, oral health is very low on the list of priorities. And I can understand that, because when you have a lot of bodily issues, and especially older people, people in nursing homes, those that are not mobile, that are dependent, they have many comorbidities, take many medications. And I understand from a sort of logical point of view why somebody puts priorities on one thing from the other. But at the same time, now it's getting better, but we've been witnessing for such a long time, for decades, this divorce between dentistry and medicine, as if there was a separation between the oral cavity and the rest of the body. And as such, it's normal to put oral health on the low list of priorities, whereas it is not. And Falk, I think you pointed out very well why it's not. But I'm getting back to informal caregivers, for somebody that maybe doesn't have the information, that maybe doesn't even take that much care for themselves, because informal caregivers are under a lot of strain. And we also know from data that they can experience also burnout. I mean, the emotional burden of taking care of your loved one, whether it's a spouse or a child, is a significant one. So as I said, I understand why the situation is as it is, but it's up to us to also work on these things and change it.
I fully agree with you, and maybe let me put that into perspective, what I provocatively said some minutes ago. I think it's very important, and I pointed that out, and you highlighted it too, that we showcase the link between oral diseases and systemic diseases, because it puts the mouth where it belongs into our body. It puts the teeth and the oral microbiome where it belongs, and it obviously also links as closely with the medical disciplines who for 100 years have looked at us as the tooth cutters and the people who put some plastic into teeth. So I think for dentistry it suits us to stress that. On the other hand, what is scientifically important is to do this in a sound way. And that's why sometimes I think, well, okay, you can probably establish any kind of associations with oral diseases, but you need to do this in a serious way, and that's sometimes missing. Whilst the two examples I mentioned, and there are others, like for example, the quality of life aspects related to oral health, or aspects of nutrition and weight related to oral health, these are established, and these are also proven by evidence, and these are good arguments to work with. And if we then add that our diseases and oral health conditions in general are just very, very frequent and very, very costly to manage as well. The cost for managing oral diseases is higher than the cost for managing diabetes and stroke combined in high-income countries, which is, if you think about it, you would never expect that. because everybody's talking about diabetes and cardiovascular diseases and so on. But if you look at the healthcare costs, dental and oral health is really expensive, especially with the current care model. It's really, really expensive. And that's why we need to push that we can do something. And to come back to what you said about the caregivers, the problem is that they won't solve this problem on their own. They need someone who helps them to solve it. It's a little bit like with developing aid, where you say we don't build schools, show them how to build schools on their own so that they can solve their own problems on their own long term and be sustainable. And I think this is something which increasingly we need to focus on. How can we educate informal caregivers, the ones you are stressing, rightly so. Also important, especially as we see increasingly data that was a bit surprising for me when we just conducted a study some while ago, that the oral health of people living at home is even worse than the oral health of people living in care homes. Usually you would expect that the informal caregivers are very attentive, that they're trying very hard because it's their spouse and so on. But obviously, despite them being so motivated, they just can't. They just don't have the skills to do this. And that's where dentistry can probably do something early on, when knowing that, for example, at this point today, they are still coming as a couple to older people, but one of them is on the trajectory where you know that this will become a problem, that we are using this moment in time to educate the other spouse how to deal with this when this happens. So to stepwise introduce and educate people, I think that's important. And that's also important with care homes. What we are increasingly seeing is that in the care homes, they want to do the right thing. They're motivated, but they just don't know how to do the right thing. And oftentimes the organization in the care homes isn't sufficient. So you need to talk to quality managers, to the directors of care. You need to educate the caregivers, former caregivers, the nursing staff regularly. And then you stepwise see, it takes a while, it takes 1 to 2 years, I would say. Then you stepwise see that things are overall improving. And probably not all of the people in the care homes will benefit from this immediately, but in the long run, you establish higher quality standards for oral care as well.
Well, now that you've mentioned this, when I initially got interested in caregiving as an undergraduate student, and I was really shocked just to share a clinical story with a nursing care resident who had a combined mobile fixed prosthodontic appliance in their mouth, and nobody removed the mobile prosthesis for over 2 years. He was a patient with Parkinson's. I mean, I think that us as dentists, we're really used to seeing a lot of maybe not pleasurable sights, but I mean, just having someone in front of you that didn't receive oral care, they were brushing everything from the outside, but the nurse that was standing, she didn't, tending to his needs, she didn't understand what a combined prosthesis is, and she didn't know how to remove it. And then I kept thinking, but who was the dentist that made and decided for this dental solution, coming back to the integrative approach and how all of us have a very important role in this? Who was the dentist that decided that a combined prosthesis that was really hard to remove is a good dental rehabilitation solution for a person with Parkinson? And then I remember in 2014, I found this wonderful paper about brushing up on the mouth project from Canada, by McNally and co-authors, and they made a case presentation of how they changed in the nursing homes, in 3 nursing homes in Canada, how they changed the entire system. And again, I'm going back to that integrative approach, because they involved the administrators and the managers, they involved the nurses, and they had a dental hygienist and assistant that kept frequenting the nursing home, and they had an oral health champion, a person among the personnel that stood out and that took the initiative. And I think that was, for me, that was very inspiring and something that really got me very interested in the topic and gave me an insight again about how important it is to have this very integrative approach when it comes to improvement of oral care.
Yeah, I fully agree with that. And what you mentioned is interesting because the key, I think, at the end is that there is not one solution. It's one of the things where you need to be adaptive. And we see this every day here with our outreach service. Every care home is a bit different. And of course, you can have your structures and how you do things and what kind of equipment you have. And I think we will touch this in some minutes. But if you look at the care homes, you need to adapt to their needs, because if they don't like you being in there, if they are rejecting it because it's just, for them it's just stress, or it just doesn't fit their timetable and so on, then you will never get anywhere. You won't get to the nursing staff. If you don't get to the nursing staff and somehow bring them on board, you won't get to the informal caregivers, because they are only indirectly available for you, because you can't go to them. They are not there usually. And so you need somehow the nursing home to assemble them and somehow educate them. So I think it's something which needs a lot of A, fantasy and initiative, but B, also some patience, because you need to always steer it until it works, until you have a concept which works. And for us, for example, when we started that, we weren't aware how difficult dental servicing in these care homes is, not with regards to the dentistry, but with regards to the organization around it. So like getting informed consent is something which takes weeks, because the caregivers, the informal ones, they are not there. So maybe they don't even visit regularly. So sometimes it takes 3-4 weeks until you get a signature under the informed consent. Sometimes they don't do this because they don't know what it is, because they are themselves not very health educated and so on. Or they're afraid, they think, I'll leave my mom alone, she suffers enough, she doesn't need to see the dentist and so on. So you really need the nursing staff to facilitate this. And this is something which for us as dentists is difficult, because we are not taught this at all. I mean, I don't know how it was in your dental education, but I remember we had, and that was really quite progressive at the time, about 10-15 years ago, we had one lecture series of, I think, around 6-8 lectures in gerodontology, and we visited the care home once for 2 hours. That was it. And now expect any dentist to go there routinely and to be happy to leave his practice. It's impossible. And I think educating them about the options and how to deal with this, providing them with some kind of scenarios, would be something I would find very helpful in dental education as well.
Falk, do you think it would be fine if we moved on to sort of the clinical part?
Absolutely. Aren't we right in it already? So yes, why not?
Well, I just want to say I'm very glad and very happy that you said something that is sort of soothing for me, which is that we need to continuously adapt. And I'm going to chain this to something that Professor Schimmel said in the last webinar when he spoke about the oral care in the elderly, which is, again, that we need to set goals, but very realistic goals. Okay. General recommendations about oral care, we take it from preventive and pediatric dentistry. And it's really questionable whether these goals can be also applied to oral care that is provided by caregivers and to this very specific population of individuals. Now, that was something that I was so scared to say, even though there's some oncoming research about the frequency of brushing and everything, but I was always, as a periodontist, for me, not to keep mentioning and repeating the general recommendations that we give for periodontal health. It's sort of a blasphemy. And hearing him say that last time, I kind of felt relieved. And I don't want to, there's there's a professor, a mentor of mine that I really value, Professor Graziani from Pisa, and he always says, never take a loser approach. Whatever you do, never take a loser approach. And I don't think this is a loser approach. I think adapting oral care for this specific population is something that can make it feasible and sustainable. Because if we try to sort of enforce general recommendations of brushing at least 2 times per day for 2 minutes, interdental care, everything that is recommended for the general population, I'm not sure that we're going to reach some goal. And one of the things that I recommend to all of my patients and their caregivers that come to the clinic is to make for each person an individualized checklist of the oral care steps that they need to make. I'm a firm believer in checklists. I suggest to all of the audience to read Checklist Manifesto by Atul Gawande, a fantastic physician from the States that highlights the importance of checklists, because even if you make them a checklist of 4 simple steps that they need to do with the person that they're tending to, it's something that they will not forget. And I always suggest that they have a toolkit, so everything that they use for dental care in one spot, and preferably, especially with people that express care-resistant behavior, to do the oral care procedure at the same time, approximately at the same time, in the same area, because that is something that, again, is quite soothing for them, so they might be less prone to resist the care. And then, depending on whether the person is mobile or and can do some part of the care themselves, or they are completely dependent on the caregiver, if the person is able to do some of the oral care themselves, I always suggest a technique that is called chaining, which means that the individual starts doing oral health by themselves, and then there's the caregiver that does some additional steps in order to be sure that the oral hygiene was done properly. This might be something in the range of finishing the toothbrushing or doing the interdental care with interdental brushes, because interdental brushes are very small, especially the elderly. If they have any musculoskeletal diseases, they might not be able to use it. And then adjust any sort of dental aids that they use in order for them to be able to use them easier. For example, if they cannot grip the toothbrush, I say to put a little towel around the handle, secure it with elastic to make it bigger so they can have an easier grip. In the literature, I've even found suggestions like putting a grippy material such as bicycle tires to make the handle more grippy, or in order to be able to hold the handle of the toothbrush easier, to put a Velcro tape around the hand. Of course, electric toothbrushes that were originally suggested for the population of individuals with special needs. And as I said, interdental cleaning, as periodontists, we are pushing interdental brushes because interdental flossing doesn't remove much biofilm. But again, we need to see whether this is completely feasible and attainable with all the individuals. And with regards to those that are dependent, especially individuals, for example, with dementia, they can be quite hard to take care, being taken care of, because some of them, as I said, can exhibit care-resistant behavior. And as I said, one of the tips that I like to suggest is to keep a routine for them to know what to expect and in what way. And there are many little tricks that may be implemented that will make the provision of oral care and oral hygiene much easier. And again, to the audience, there's a wonderful researcher, Rita Jablonski from the States, that did a lot of research on care-resistant behavior, and they made sort of a proposition of different behaviors that can be exhibited by the caregiver that might reduce the chance of care-resistant behavior, such as putting a mirror in front of the individuals while doing oral care. Because if you come before the person and try to, in front of the person and try to provide oral hygiene, this might induce care-resistant behavior, because this might trigger some emotional responses of perceiving the caregiver as a threat. So go behind the person, give them a mirror, and then try doing oral care. This might reduce, again, the chances of resisting the behavior. Or even something something like bridging, which means that you put a toothbrush in the hand of the person that you're providing oral hygiene to, and you start brushing their teeth. So you engage their senses. They sort of have the feeling of what you're doing because they're holding something. This was proven to reduce the stress for them. There are, with these individuals, again, we need to make sort of attainable, realistic goals of what we can achieve. And I'm not saying this is not a loser approach. It's just something that we need to make feasible and a daily thing that will improve their oral health. Now, as for the dentures, and Falk mentioned dentures, one thing that I've learned from my interaction with caregivers is that they don't know that dentures need to be removed. So dentures just keep being kept in the mouth, which can contribute to candidiasis, which can then further contribute to pain, discomfort, itchiness, inability to eat, and that has a huge potential to cause problems further down the way. So it's something that always needs to be stressed out. They need to be taught what is in the mouth. Oral hygiene is a very intimate process. So they need to be taught, the caregivers need to be taught what is in the mouth of the individuals they're taking care of, and how to deal with this specific. And Falk really said it nicely. Now we're witnessing a completely different oral status of an 80-year-old than we did 40, 50, 60 years ago. This was a mouthful. I said a lot of things.
Well, sorry.
No, go ahead. I was about to ask your opinion on that. So please.
Well, I think that was, yeah, I agree to most of these things, and we are seeing the same, that you need to just be very pragmatic in these situations there. You can't expect everything you would expect in a practice setting, and everything you would expect with regards to oral hygiene from maybe a healthy adult. And you are surprised, exactly as Larisa pointed out, how little many people know about teeth and their own teeth even, and also how little the informal and also the formal nursing staff, caregivers know about the teeth of the people they deal with. So we see this, I wouldn't say on a daily basis, but probably it is a daily basis, that dentures aren't removed at all. So it's not unusual, it's not a surprise to me at all. I think there are also a number of smaller things which we would recommend, both the formal and the informal caregivers, which could help. And one of the most simple things when it comes to preventing caries, for example, is that they use highly fluoridated toothpaste. And that is something which isn't done very often. I do this for every of my very old patients, that they use the 5,000 ppm toothpaste. Because the high fluoride amount has just been proven to, for example, prevent and arrest root caries quite effectively. And there are also some studies with regards to mouthwashes, for example, which obviously are on the one hand interesting because they're easy to apply. On the other hand, I'm always a bit careful with mouthwashes in the elderly because of aspiration pneumonia. But if that person is so far able to use a mouthwash, then it's also an interesting option because it's damn easy to use it, for example. And these kind of little aids, the chemical aids, they are a big help in at least dealing with, when it comes to the fluoride with caries, and when it comes, for example, maybe with regards to the chlorhexidine occasionally with perio, so you can at least chemically support the mechanical oral hygiene. Because that is something which for many is really, really reduced. We have even patients who don't allow us to brush their teeth, who only allow to clean the teeth, to wipe them off basically. Even that happens, and you need to deal with this. And it doesn't make sense to force that person into brushing their teeth. And it's better to be pragmatic and to choose another, maybe not as effective, but at least one way of doing that. So overall, I fully agree with you, Larisa. It's tricky, it's not easy, and I think what dentists need to know when they go there is that, as I said, it's a completely different ball game. And what we learned over the last months when we started to visit there every day is that normal dental care, like we bought a mobile unit. I think we have used it once or twice in the last 3 months because it's just something it's not applicable in many situations there. That's the same for other things, that a number of things aren't applicable, and in many things our main task as dentists going there is to talk to the people. That's already 50% of our success, is talking to the people, talking to the nurses, talking to the quality managers, talking to the care home directors, to establish the environment that there could be better oral health and better oral hygiene, because that makes a lot of difference if the nursing staff somehow has a little bit more time for oral health, that they see that oral health is a priority in their care home, that they can ask questions to dentists or at least dental staff. That we see from a number of studies when we, for example, did interviews with nursing staff in care homes, that they are so unsecure. Allowing them to talk to a dental professional every 3 to 6 months makes a big difference in their confidence and their abilities of how to deal with the oral health of these elderly people and these complex situations. And as you say, showing them once how to remove a denture can make a huge difference for the individual. It takes us 15 seconds, but it made a big change for the caregiver and also the one who is giving care to.
Thank you both for this whole set of clinical tips for our audience about for caregivers to take care about the patients. Taking a look at the time, we are arriving almost at the end of our session. So I would like to give a chance to our audience to ask questions to you directly. So let's have a look. Yes, here we have a question from Anna. Older people may suffer frailty, especially in nursing homes. What would be the role of dentists in terms of care as part of a multidisciplinary approach? Would you like to have a... Oh, yes.
Larisa, do you want to answer it or shall I answer it?
Well, I mean, this was something that was that I also suggested the last edition of the SUNSTAR Conversation PRO, because Professor Tsakos and Shima went really in great lengths about frailty and the oral care in the elderly. I think that among the dentists, I don't want to make a general assumption. I don't want to make anyone feel bad, but I think that we don't value enough how much we can help with enabling our patients to be able to have normal chewing activity. And loss of teeth and inability of chewing is related to frailty as well. So I think that the role of dentists is important to restore this chewing ability, and in that way impact the frailty. I don't know, Falk, whether you would you think anything differently, or you might add something.
Of course, what is important is what you said, and also interaction with other disciplines. I think this is something, especially for these multimorbid population, is quite important, because they usually take 25,000 different medications, and they have 5 different doctors caring for them, it's quite a challenge to interact with all of them, but that's one of the main tasks we're having. So if we are providing dental care to these people, let's say a tooth extraction usually needs coordination with minimum 2 doctors before you can attempt the tooth extraction. And that makes it more difficult and complex than the usual care as well, but that's what we are facing. We have to accept that.
Great. Thank you for your answer. Oh, there is already another question popping up from Mana. Apologies. Okay, what are your thoughts on Xylitol products, especially for this population? No, this was not addressed, Mana. So, Larisa or Falk, would you like to have a go at this question?
Well, I can try. The idea behind the Xylitol is of course twofold. You reduce the amount of cardiogenic sugar by using something which is sugary, so sweet, but not cardiogenic directly. And you possibly, although that's a bit something which I wouldn't emphasize too much, you also have an antibacterial effect to some degree. I think the Xylitol products, they are evidence-based. We know that there are studies out there, and there was a recent Cochrane review, but not in the elderly. And I'm not so sure if the elderly are the perfect population for this, because on the other hand, you want them to have a carbohydrate-rich, high caloric diet on the other hand. So that's always the difficulties we are facing. We want to get a lot of calories in these people at some point. They don't taste a lot of stuff, so you need to make it really tasty and sugary and so on. And on the other hand, that's of course a problem for the teeth. But I wouldn't know any study, to be honest, with regards to xylitol in the elderly. But maybe I just don't know the study.
Okay. Would you have something to add, Larisa, before we go on the next question? Or I think the answer was pretty comprehensive,
pretty clear.
from Falk. So let's go to the next question. Maybe what has been the impact of COVID on this caregiving situation? Larisa, would you like to have a go?
Well, in Croatia in particular during COVID, and I think this was the case in entire Europe, the elderly in nursing homes, for example, now when I'm talking about them in particular, were not allowed to see anyone from the outside for months. Okay, so of course they receive formal caregiving from the staff that works at the nursing homes that might have been strained already because they were short-staffed, because some people got infected, weren't able to come to work. But then they also didn't have their family members that also provide informal care within the setting of a nursing home. And I don't even want to get into the psychological state and status of being so divided from the elderly world. And not only nursing homes, anybody that was homebound and that couldn't see their regular caregivers if they were receiving formal caregiving, or other members of their social circle that were providing informal caregiving. So I think in terms of the impact of COVID, it was tremendous, and it was very negative. I don't know, Falk, whether you would agree.
I fully agree, and I think that's some of the things we haven't looked at in quite some detail, and some of the things maybe at the moment the impression is people don't want you to look at, because of course there was some kind of political direction which was probably justified at the beginning when we didn't know a lot about COVID, but maintaining these restrictions for that long, I'm not sure it was needed, and of course we will see the effects, the side effects. And when we are looking into the elderly now, and in some of these care homes we're going there for the first time for 1.5 years now, of course you see it. And I would be very interested, but that's not the debate for today, to look into the mouth of children from socially deprived families, where, for example, here in Germany, they usually at least get some care in what we call group prophylaxis in schools and these kind of areas, because they never visit a dentist in many cases. And that didn't happen for 1.5 years either. So I would be very interested to see the effects of these restrictions on these especially vulnerable, both physically and also socially vulnerable groups.
Great. Yes, indeed, COVID has had an impact on a lot of things, and caregiving, indeed. Caregivers probably also suffered a lot from this situation. We don't have any more time for more questions, but I would like just to summarize from what we just said this afternoon. Caregivers are actually really very important people, key persons in the oral health journey of a patient. It's a collaborative work between them, the dentist, and the patients, but also the structures and the need to new system probably are needed from what's to better the oral health care in link to the oral health in general, in the health in general. Sorry. And also because there are, however, there are barriers, but there are solutions that are currently implemented in various countries to try to find solutions to help the caregivers, but also education from the dentists and all the clinical tips that you gave will also help the caregivers in their daily task to take care of the patients. So with that, I will need to close the session right now. First, with a big thank you to both of you for all your inputs and for spending time with us. Thank you also to our audience for their attention. We hope you got useful tips, information for your daily practice from tomorrow on. And we would like also to invite you to join us to our next webinar next month in November, where we will have a special webinar because we will celebrate the winning papers of the World Peer Research Award with the winners, specifically on one generic condition linked to oral health. More details are to come. Please make sure to stay tuned, subscribe to our YouTube channel or to our social media platforms, LinkedIn, Facebook, to get the latest information. And with that, again, thank you all, Dr. Schwendicke, Dr. Musić, and to our audience, and see you soon then.
Thank you.
Thank you.
Thanks. Bye.